Hello, guys, and welcome back to Counter 10. My name is Arnie, and on today's episode, I'm going to be reviewing the 2025 second sitting paper that just happened last week. Now, you might have already seen my live perusal demonstration for the first sitting paper of this year earlier on, and I'm going to do something very similar but slightly different today. To help me do this review and look at the questions, I'm going to be using the tool AI, which is now becoming a very popular tool among trainees studying for this exam. Now, by no means am I an expert at AI. I rarely use it for anything, and to help me do this, I've actually enlisted the help of two of my colleagues, Robbie and Harry, who are currently in the midst of studying for the next sitting right now. They're freshly minted ITs turned BTs, and they're in the thick of their study mode, and they've been using AI to help them with their studying throughout their whole process. So they're going to come on today to help me break up this episode into two parts. The first part is really an understanding of how AI can be useful for trainees studying for the primary exam. Coming from someone that never used AI when studying because it wasn't available, anyone who is thinking about studying, that part will be very useful for you because the tips and tricks that they've come up with really help to streamline studying. And through our conversation, you'll hear me say that AI is crazy because in my mind, this kind of tool, this kind of power, I just wish I had available to me when I was studying. Because not only does that mean in my mind, studying would have been more efficient, but it would have given me more time for family, friends, and a better work-life balance. In the second part of today's episode, we're going to be going through the written paper, each question one at a time, and comparing the notes that I come up with during perusal to what AI generates in the same allocated time. This is hopefully a good demonstration for you guys to see that AI is reliable and most importantly, credible in the information that it's spitting out so that you feel more confident using it. By no means in this episode am I endorsing the use of AI in substitute for books. I'm not getting paid by any AI company to do this episode, but it's just the next evolution that I can see in making life easier for the trainee while studying for this primary exam. So I really want to thank Robbie and Harry for jumping on. We recorded this late at night on a Saturday night after they had both worked a long shift. So you might find us in the last 5 questions of the written exam trying to just power through and get through it as fast as possible. So I hope you guys really enjoy this. If you're already up to date with AI, you can just skip to the second part of our review of the paper. But even if you're using AI, I think you'll find the conversation very interesting. So I hope you guys enjoy it. I've learned a lot from Robbie and Harry in this short amount of time. And with that said, let's dive into our conversation.
1, 2, 3, 4.
Hello, guys, and thank you so much for joining me on this episode of Counter 10. I want to thank you guys for taking time out to go through this. I would consider myself an AI virgin, so I'm hoping that I learn a lot from you guys. And really, we're going to divide this episode into 2 sections. The first section is you guys are hopefully going to teach me how AI can be used as a tool for studying now. And then the second section is when we're going to go through the most recent exam paper. And I'm going to try to put my knowledge up against AI and see how we fare going through the perusal of the most recent paper. So why don't we go straight into it? And the first question I wanted to ask you guys was, using AI always a part of how you were going to start studying when you set up going through the curriculum? And if it was, how did you feel towards it before you started using it?
I first of all, yeah, thanks for having us. But no, I'd never really used any form of AI before this year, and I don't think I really intended on using it initially. I don't even really know how I kind of fell into it. I think I kind of just started using it to clarify questions that I had, or trying to like get better explanations, or trying to like dumb down concepts that I was sort of struggling with. And then I think from there, I sort of just found it a little bit easier. And then I sort of just toyed with it a little bit, and I saw that I was able to just put short answer questions into it, and it would give like pretty good short responses back that kind of covered all the topics, and I would include examiners' reports, and so it made sure that it touched on all the key points that the examiners wanted. And then from there, I kind of just started using it more and more, but it was never really an initial intention, and it just kind of grew.
Yeah, nice. What about you, Robbie?
For me, it's actually, I was quite ambivalent towards it initially. I had no intention really to use it. I thought I couldn't really trust its credibility and reliability. And it was actually Harry who convinced me to really start using it more. That combined with maybe one of the other fellow ITs who used it pretty reliably. And I think what really put me over the edge with using it and implementing it really quite regularly was the fact that you can upload textbooks to it and it can synthesize those textbooks instantaneously. And with that, it can actually give you citations and references from the textbooks when it's giving you SAQ answers. So that issue that I had with reliability and dependence was initially gone, like immediately gone. And I knew I could have a lot more credibility with the answers. And I guess with a lot of the SAQs, the model answers that we use tend to be from sources like Propofol Dreams and Ketamine Nightmares, or user submitted ones, which phenomenal. And they've helped me so much, but it's sometimes hard to know how reliable they are as well, because it's not directly from a textbook. So AI seem to kind of circumvent that and really make my study a lot more efficient as well.
Yeah, there's a few key points that you guys both said there, and I want to just touch on what Harry said first. Like, from someone who's never used AI, you said you were starting to toy with it. What do you mean you were starting to toy with it? In what way?
Um, I guess it was more just using it to clarify concepts, and from like I would ask it to explain, I don't know, for example, FRC. And then if I still didn't really understand that concept, I could just kind of keep going back to it and be like, no, I don't get that. Please explain it more, break it down more, make it dumber. And it was able to do that. And if I had specific questions about some nuance, I could ask it that, and it would give me an answer rather than, because initially I was using textbooks, and I found that even reading textbooks could still be quite convoluted, and it wasn't necessarily aimed at, I don't know, it was kind of sometimes just difficult to try and wrap your head around what some of the more difficult concepts were. And so then I found I was jumping textbook to textbook to try and understand one single small concept, and that would take so much time. So then that's when I sort of was like, well, can I just ask ChatGPT? Is that going to be something that just gets all of that searching through textbooks and take that out of the equation and just go, here's an answer, and it's done it in a fraction of the time. And so that's kind of where I was like, yeah, it speeds so much up, and it makes my time much more efficient. And I think that's the main benefit that I've really got.
Yeah. And when you did that and it started giving you answers, can't touch on what Robbie was saying, what was the credibility like when you compare it to what textbooks say? Is it
initially I was also really skeptical of what the answers were. And like I've definitely seen a few of the answers that I've gotten back where I've been like, oh, that doesn't seem right. That seems like a mistake. And you can kind of challenge it. And there's been a couple of times it goes, yeah, that was just a blatant error. And so it definitely still does make mistakes. And I think that's one thing to be aware of. Like, it's not perfect. But yeah, I don't know. I've found I feel like the more I've used it, the more I've known how to, like, what prompt to put in to like make sure that it gives an answer that I'm happy with. And kind of, I don't just use ChatGPT. I'll use Gemini and kind of copy and paste what ChatGPT says into Gemini as like a double check. And I'll be like, okay, is this right? And so I've got two sources of kind of clarification.
that's crazy.
Yeah,
That just blows my mind. And are these, because I don't have either ChatGPT or Gemini, are these free to use, or are you paying them?
They are free to use, but I use the paid ChatGPT because, as Robbie mentioned, with the paid version, you can upload textbooks and files. So I've got like this, they call it like a project. And so I've got, I think it's like 15 textbooks uploaded into that. So I've got Miller's, Stolting's, Power and Cam. I've pretty much turned all of the text from Mac 95 into a couple of files, and I've put that into it. And so I'll just be like, yeah, using all of these uploaded resources, give me a model answer for this one SAQ. And it'll reference where it pulls each piece of information from and be like, yeah, so according to Miller's chapter 3, this is the definition of FRC. And then it might even be like, you could throw a diagram into this SAQ for like full answers. And I could just be like, which textbook has a good diagram of like the hysteresis curve? And it'll be like, yeah, Miller's has got a great one in this chapter. And so then I can just pull up Miller's and I can scroll through it and go, yep, that's great. I can kind of understand that. So like ChatGPT is terrible at making graphs or like doing diagrams, but it will tell you where to find ones. So it kind of gets around that issue.
I just find what you're describing amazing, because like I would consider myself a dinosaur now, because I only sat this exam 3 years ago, and in 2022 no one was using AI.
Yeah.
And you could probably make an argument back in 2013, back in 2000, no one had Mac 95. And so anyone who's had Mac 95 will say the only way to study is Mac 95. Anyone that didn't have Mac 95 would say you had to learn through textbooks. And there's been renditions or advances that have essentially made the way that we study easier. And part of this is the way that someone studied, like the way I studied in 22, people will feel like that's the way you should study because that's how I got through it. And, I went through that grueling, taxing time. So why shouldn't people right now be going through that grueling, taxing time? But if you could make life easier and have the same reputable sources and be doing the same thing and spending more time with enjoying life and less time studying or studying more efficiently, why are we so hesitant as a community to be like, this is actually for the better? And I think some people, regardless of what they hear in today's episode, will be like, I'm never using AI. And that is fine. And I think probably majority of us would, from what you were saying, you start off with that hesitancy, and as you got more comfortable with it, you're like, okay, I can do this. Because this idea of uploading textbooks, as you and Robbie mentioned, and then essentially you're just using textbooks to be quickly resourced and give you an answer that are recommended text. That's the highest level of credible information you could have.
Yeah.
It's crazy because we did this, I did this survey, and we asked current registrars how they study for the primary exam. And the common themes were 58% now use AI to study. 41% of registrars choose a study method that is easy to access, and 25% would recommend AI to others. And it's probably more, I would say, now. Yeah. And then the biggest influence of how people study is speed of access to information.
Yeah.
But the most important factor is not speed, it's credibility. So when you've uploaded these books and you've cross-referenced it, you still find that credibility is there across platforms?
Yeah.
Not always, for the most part, but not always.
Well, in what parts is it not there?
So every now and then there are little small discrepancies in the results that it provides. But I think the credibility is heightened so much because it does give you the exact chapters and sometimes even the exact lines from which it has sourced that information, so you can sort of check it very quickly. Whereas before uploading the textbooks, it kind of gives you a nebulous answer that you're not entirely sure where it's coming from. It might be hard to find the source. So I think the credibility has increased dramatically, but not to the point that it's free of faults and free of errors. But then I guess it begs the question, is this better than the rate of human error? And to be honest, it probably is better than the rate of human error. And at the very least, you can easily cross-reference and check yourself, which is not something that you have with a lot of the other references that we do use for the answers that we formulate.
When you're reading this information, say we take that example of explaining how what FRC is and what the significance of FRC is. When you're reading it for the first time, does it stick with you the same way it would if I was to write out that information myself? Because some people might be, they might learn by typing their notes on Anki decks, or they might just handwrite their notes. Do you find that you're retaining the same level of information through these avenues?
I think that's really hard because that's been my biggest concern. So I am doing all the SAQs and then I'm handwriting all of them out onto flashcards. So I'm trying to get the best of both. Because my worry is, yeah, it might be easy to get an answer that I think is good, and then I read it and I go, yeah, I'm happy with that. I might understand it, but then it'll be gone the next like 2 days later. So I am still trying to write things down to try and keep things in my memory. But I don't know. It's kind of hard to say. I haven't really used ChatGPT to study before, so I'm not sure. I hope so.
What about you, Robbie?
I think a lot of my retention comes from understanding, understanding concepts and principles. And I think AI has probably helped me with that a lot. Because, for example, let's say like FRC, if I get into a rabbit hole about understanding different lung volumes and capacities and hysteresis curves, then going through to different textbooks, like Harry mentioned, is so inefficient. It can take so long. And then my overall understanding of the concept can be so obfuscated by just digging down into different textbooks. Whereas if with AI, I can ask it really pointed, directed questions and get down to understanding the concept much more efficiently, then I don't get lost in the forest, so to say. And I can really get a better understanding much faster and more efficiently. And I think that helps me retain it faster as well.
Yeah, awesome. Yeah, I found when I was studying, the way my brain worked was I had to rote learn a topic. And if that meant I had to rote learn a curriculum, that's what I had to do. Like I had to go through the curriculum. I think I went through it in totality 4 times. The first time it took me 8 months. The second time it took me 4 months. The third time it took me 2 months. And the last time it took me a month. And by the end of it, I had, it's like, I'm in my office at the moment. I had 9 folders of notes and then like 120-page books of mock SAQ model answers for every topic. And I had read those 4 times in a row, like 4 times in total. And it's what I reference to this day when I'm doing my episodes and doing my topics like that. These are the notes that I have. And I can remember like when I'm reading them, I can remember like, oh, I wrote something here and there's a diagram here. And like that part of it, I find you probably couldn't replicate in ChatGPT because it's on your phone, it's on somewhere, and it goes away. So that muscle memory of you being like, I remember writing that diagram or something like that. So I really like what you said before, Harry, was like you write down your answer on a flashcard and then have that available. Because I feel like that's still a really key important step. And the next thing I wanted to kind of touch on is let's give an example. Let's say my next topic I'm going to be covering is renal physiology. And there's got lots of subheadings on Mac 95. And one of the subheadings is functional anatomy. And one of those LOs is outline the functional anatomy of the nephron. How would you guys go about tackling getting information regarding that learning objective?
Well, the way I've been doing, I haven't really been looking at LOs so much yet. I'm planning on just finishing the SAQs and then using the kind of going back and looking at the LOs, which I don't think I'd be able to answer, and then trying to make cards out of that. I'm not sure how I'd really broach it when it comes to LOs, simply just because I haven't done it yet. I wonder if, because I know with like Mac 95, it does have like the links to like deranged physiology and all those other things. So I wonder if like I'd just click on them, open up those links, essentially copy and paste all that information in and just be like, can you synthesize this information into something that might be like high yield for studying for an anesthetics primary, and then it would spit something out, and I'd kind of just toy with that until I worked out the best way to approach that. But I don't know, because I haven't looked at doing it with just LOs yet.
Would that be the words that you put into it? Like make it so way that like...
Yeah, so with like the projects where I kind of uploaded all the textbooks, you can have like rules. And so my rules for my SAQ answers are use the uploaded files as your main source of information. The answers need to be able to be handwritten in under 10 minutes. And the questions are aimed at the level of someone studying for an anesthetics primary exam in Queensland. And so those are like my rules that it kind of should stick to. So sometimes it'll give like longer answers, and I might just need to be like, make sure it's able to be handwritten in under 10 minutes. And then it'll kind of synthesize things, but it generally sticks to those parameters.
It's crazy. I'm going to keep saying it's crazy because everything's just blowing my mind. It's just completely blowing my mind. What about you, Robbie? Are you using LOs to study?
No, so I'm using SAQs as well.
Hmm.
But I think similarly, when it comes to approaching LOs, I'd probably look at the most readily available resource, which for me would be Mac 95, the one that I find most efficient. And I'll do a read through that. And if I find that it doesn't answer the LO, I would probably honestly just copy paste the LO into ChatGPT. And I'd say, like, using the supplied textbooks, summarize the information pertinent to an ANSCA primary exam sitting trainee and see what it spits out, with the similar rules that Harry has in place as well.
So then, given you guys are studying SAQ based, say I had an SAQ, which is again a common renal SAQ, discuss the determinants of renal blood flow. Would the starting point just be put the SAQ in,
Yeah,
and have those parameters in and see what spits out?
yeah. So
with the examiner's report too.
yeah, that's
What,
exactly
what does that involve? Do you then put in the examiner report to be like modify the model answer to incorporate the examiner's report?
My usual input will literally just be, this is the question, and then under that I'll say this is the examiner's report, and then just copy and paste, and it will kind of just follow their comments and say, like, kind of tailor it towards these things generally got higher marks, these things didn't get marks. So yeah, it would just kind of tailor the answer towards that.
When you guys compare that response to, say, the quote unquote standard of ketamine nightmares, Amanda Diaz, propofol dreams, how does that stack up?
I find it's a lot more structured. Usually, that's the biggest thing I think, which helps me learn and retain it. And I find in general, it tends to be a bit more concise. So, propofol dreams or the ketamine nightmares can have a few extra salient points that are in there that are maybe a bit tangential, whereas ChatGPT tends to have a much more concise and structured answer. And I guess every now and then also I can copy, I think Harry does this too, but we copy paste some of the model answers in and just say like, I guess like criticize this answer or structurally, critically appraise this answer in accordance with the previous examiner's report or in accordance to the textbook information. And then it can give you like a little nice summary about things that were good, things that were bad, or things that should be improved upon. And you can ask it to actually integrate some of those points into the answer that it gave you previously to come up with a big cohesive answer if there's things that you feel like are lacking.
Yeah, awesome. So good. And so the last thing I want to ask you guys is, because currently we're in, well, some people are in Viva mode. You guys are in the thick of studying for next sitting. How could we potentially, or the people sitting right now, use AI to help them with Viva practice and Viva prep?
So I think Harry was great with this actually when we had our IAC.
I'm trying to remember what I did. I think I copied and pasted the LOs for the IAC into ChatGPT and essentially just said, these are the learning objectives I need to know for this exam. Keep just giving me scenarios that would be expected of a anesthetics IT. And so I would be able to get a new scenario and I would just be like, yep, this is how I would approach this situation. This sounds like a difficult airway. I'd call for help, yada, yada, yada. This is what I'd do. And then it would kind of criticize my response and how I approach that situation. So it was good to get feedback. In terms of the Viva, I suppose you could do a similar thing. I think I haven't really looked at Mac 95 for Vivas yet, but I think there is a section for Vivas. So I wonder if you could just like copy and paste and be like, these are example Viva questions. Hit me with 20 Viva questions. And then, yeah, put in your answer and see what they say. But yeah, I don't know. I haven't really looked at it, but I think it'd definitely be a way that you could kind of integrate the Viva practice into it as well.
So you're using essentially the AI tool as your examiner that you are answering questions to.
Yeah.
And you're just going deeper and deeper and deeper until you're like, I can't answer anymore.
Yeah.
And I guess because you were saying you could modify it initially when you were playing with it, you could modify it to make it simpler. If you were finding the Viva questions being too hard, you could then as easily tell the AI to make these questions easier.
Yeah.
And so
Absolutely.
you could gradually increase the difficulty level.
Yeah. So I guess if you like just started off with Vivas and you're just like, I just want something simple so I can get used to like the structure of how to do this, and then just progressively be like, yeah, make these more complex. Or like if you knew that there was an area that you found particularly difficult, you could just be like, yeah, just focus on, I don't know, equipment for the next 50 questions. Yeah, but I haven't really played with it in that aspect yet, but that's, I think, how I'd approach that.
Could you ever, like, I was trying to think, could you ever see a world where we're sitting our primary exam opposite an AI tool and we're just giving answers back to an AI tool and there's like a minute
Miller's
and there's a
thing,
minimum pass mark and it's like you got to get to 5 of these questions or get through 10 of these questions and that's the pass mark. I could see that happening.
I could see it.
It's not far
it's not
fetched.
super far fetched.
Yeah. But
I think AI would be a lot more encouraging as well than I've heard some of the exams are.
maybe it's the intimidation. I remember on the day when I sat my Viva, there was certainly intimidation factors from
Yeah.
some of the examiners, and some had the way to make you feel really comfortable. And we're all human. That definitely changes stress levels, and we know stress is related to anxiety and performance. And so that's a huge part because you might be amazing at smashing Vivas out in a relaxed environment when you're doing a Viva with someone that you're totally comfortable with. But when you flip that around and you are not comfortable, the things that you find really easy now become really hard. And so maybe that is actually a better tool because it gets rid of some of the emotional context.
Yeah.
If you know you're going to just be going against the screen and they're going to be asking you a set of standard questions.
Yeah. They just completely get rid of like the interpersonal like variability, really.
And maybe you have an examiner there as like just a cross-referencing person to maintain like neutrality and ensure that there is not tampering or anything else going on.
Yeah. I mean,
Wow, maybe we've just solved the crisis of not needing examiners for the future.
yeah. And then just get ChatGPT to mark everyone's questions, get all your feedback done in a day.
Well, I think
That's it.
I think this might actually link in nicely with our second section, which is the section that I'm more worried about, and that's putting my knowledge against the knowledge of an all-knowing AI system that has the information from Miller's, Stolting's, my favorite book, Power and Cam, and reviewing the latest 2025 second sitting exam paper. You guys ready to do that?
Yeah, definitely.
Cool. I think you guys all have the paper. And so the plan is going to be, we're just going to do this as a 1 minute perusal. And what I want you guys to do is, if Robbie, you read out the question and we'll just go through from 1 to 15. And after the first minute, we'll stop, we'll review the first question. I'll have 1 minute to just go through what I would write as what would be the key points for my model answer in what I would write in this exam setting. And then you guys ask ChatGPT what would be the key points to write in a perusal to encompass a pass mark answer in a 10-minute setting with your parameters that you guys have. So it's not so much, can you give me an answer for 10 minutes? It's like, what do I write in perusal to ensure I have all the key points? Because you can't obviously write the answer in 10 minutes, but what are the key points that we want to hit in that perusal time? Does that make sense?
Yeah.
And so when you guys are ready, I've just got a mini stopwatch here. So I'll just flick over to like 1 minute each time and we can get started.
That's good. I think we're just missing the very first question on this, potentially.
Let me see if I've got the first question. And I might do. Yeah, I've got the first paper here, first question here. So I'll read it out, and if you guys need me to read it out again, you can put it into the system. But the first question is cardiovascular physiology, left ventricular diastole, answer in a separate book provided. Oh, that's what you're talking about. It's not
Yeah.
a separate book. Okay, we're gonna omit that. We're gonna omit that
Perfect.
question. So why don't we just go with the second question then? What's the second
Perfect.
question, Robbie?
Do you want me to read it out?
Yeah.
All right. So A, draw and label an oxygen hemoglobin dissociation curve for adult hemoglobin. B, why does this curve have this shape? And C, what advantages are conferred by this shape?
I'm already like the first part says draw and label, so I know it's going to look terrible.
All right. I think that is 1 minute. So I will be the guinea pig and I will say what I have in my quote unquote 1 minute. So for the draw and label, it's pretty self-explanatory. I just wrote down I would draw and label the diagram. On the x-axis and the y-axis, you would just have the classic sigmoid shaped curve. And so SATs and PO2. And then the key points that I said that I wanted in my perusal was making sure I remember to label the P50, the P90 being the ICU point or the drop point, and then recognizing the P50 would be at the SPO2 of like 27 from memory. And then I said the sigmoid shape is due to the O2 binding. And then the advantages and disadvantages I would relate to both concepts of offloading and the shifting of the curve by either hydrogen, changes in CO2, or changes in temperature. And I then put this into clinical context and try to then think about the placenta and the different affinity of oxygen based on your hemoglobin species. So where you want a higher affinity for fetal hemoglobin and an increased offloading from the maternal blood onto the fetal as my clinical context of why this shape is important. So that was my 1 minute perusal. How does that stack up to ChatGPT?
Pretty close, to be honest. So mine has also written axes. So it's written x-axis PaO2, and it's written you can do millimeters of mercury or kPa, y-axis HB saturation percentage, shape sigmoid key points to label. So the P50, and it's given me values, the plateau region, the steep portion, so the large change in saturation for a small change in PaO2, and then it's also told me to indicate the physical modulators. So right shift with CO2 acidosis, temperature, and 2,3 dpg, and left shift for the opposite, including fetal and carbon monoxide, carboxyhemoglobin here as well. And then it's said to annotate sigmoid due to the cooperative binding of O2 to HB. And it's given me a little tip to say simple neat curve with 3 to F4 annotations scores well. Then it's gone to part B, which is the molecular basis, saying that hemoglobin is a tetramer, cooperativity, and then that this creates a sigmoid shape. And then with the influences, again, the Bohr effect and the modulators. And for part C, it just said the advantages, which pretty much has exactly what you had there, Annie, as well.
Yeah, nice. How's that compared to your ChatGPT answer, Harry?
The first part was pretty much the same, almost word for word with what Robbie said. My part B was saying, yeah, it's got cooperative binding. So binding of each oxygen increases affinity of remaining sites. So you've got your allosteric effect. Due to conformational change from the T to R state of hemoglobin, and then advantages of shape. It's got small portion, steep portion, so small decrease in PaO2 leads to a large increase in O2 unloading in the tissues, which facilitates delivery. It's got the flat plateau at high saturations, and it kind of goes into that a little bit, and optimizes both O2 loading in lungs and unloading in tissues.
Yeah, nice. So that was, I felt like I did it pretty well. I felt like I was okay with that one.
You did really well.
That was a nice one. So the key ones there would be making sure that we somewhere mentioned cooperative binding, somewhere talked about it being sigmoid, which I think everyone would, and then somewhere said their main advantage would be offloading in some capacity to the tissues, whether that's an example being the placenta, an example being a highly metabolic tissue where you're having right shift of the curve, and you're having the Bohr effect. Those would be the important things. So those would be like the 3 key things I would take away from that. That's pretty good. Like, let's see if it gets a bit harder now, because my knowledge will peter out. Go for the next one, Robbie.
All right. Outline the effects of class 3 obesity, BMI greater than 40, on respiratory physiology using the following headings: lung volumes, respiratory mechanics, VQ relationships.
All right, that's a minute. All right, I'll go first again. This one I think is also set up. Well, I think the examiners have been nice because they've given you headings for the first, like, we didn't do the first question, but they've given you headings. So I just can't remember, did they define class 3 obesity, BMI 40? So because because they've defined that, I would not have a definition. I would just go into the 3 headings. And so for lung volumes, the main changes I want to talk about were changes in tidal volume, with potentially increasing or decreasing metabolic rate, changes in FRC and your expiratory reserve volume. And then I couldn't remember what happens to absolute lung volumes. I just left that there. I said for respiratory mechanics, I would talk about compliance and say that there would be a decrease in chest wall compliance due to the increase in adipose tissue. And that's kind of what I left it at. And then the main thing for VQ relationships would be a decrease in FRC, which would decrease our VQ matching. And I couldn't really relate that to blood flow, but I knew the key thing I wanted to touch on is how this would be clinically relevant, because I think that always in my mind gets extra points. And so then I would try to relate this to the clinical of what happens when you then anesthetize someone with BMI 40. And that would be a further compromise on someone that already has a decreased reserve. So further compromise of FRC, a further increase in airway pressures with ventilation, and increased propensity to therefore have things like pneumothorax, atelectasis, secondary infections, all these other things. So that's where my brain was going in that 1 minute perusal. How does that sit with ChatGPT? I think ChatGPT will definitely beat me here and have a much better outline.
Mine was pretty similar, to be honest. So for lung volumes, mine just starts off by saying decrease FRC due to chest wall and abdominal fat compression. It says RVs usually preserved, mild decrease in TLC due to restriction. Then it goes through respiratory mechanics, as you said, decrease in compliance. It talks about increased work of breathing due to increase in elastic and resistive load. Increase in airway resistance due to the smaller FRC, and increase in oxygen cost of breathing. So I guess just work of breathing. And then VQ relationships talks about decreased FRC and how that the effects of that with closing capacity. So having airway closure and atelectasis, increase in intrapulmonary shunt and VQ mismatch, decrease in PaO2, so resting hypoxemia is common, and then you have limited reserve under anesthesia or when they're supine. So similar-ish.
Mine seems to have expanded a tiny bit. So mine's gone for lung volumes, it's gone to 5 main points there. So decrease ERV, expiratory reserve volume, which it says due to increased abdominal mass, compressing diaphragm, and decreased chest wall compliance. It says that's the most consistent and largest change. Then decrease FRC with no extra points really than you guys have already mentioned. Then decrease TLC, which it says mildly reduced in morbid obesity. And then like Harry said, also RV is usually preserved and a vital capacity is reduced largely because of a decrease in ERV. Then respiratory mechanics, it's split up into 5 as well. So an increase in chest wall and lung elastance, so a decreased compliance, like you both mentioned for the same reasons, increased work of breathing, which is due to decreased compliance, and increased resistance from airway closure and increased oxygen cost of breathing. Increased airway resistance, which is due to small airway closure from decreased FRC and worsened in supine, and decreased respiratory muscle efficiency. And then like Harry mentioned as well, that increased oxygen consumption, CO2 production due to the increased metabolic demands. And VQ relationships, it has 4 separate settings. So first is VQ mismatch, which is due to decreased FRC. And then shunt physiology is the second one, which is due to atelectasis and dependent lung regions. And then a decreased PO2, so hypoxemia, which is from both atelectasis and VQ mismatch. And it says CO2 handling, generally preserved because of a high ventilatory drive. until severe disease or obesity hyperventilation syndrome. And then it's given me some little exam answers tips as well. So it says a neat table with 3 headings scores highly. Extra credit if you mention supine/anesthesia worsens changes, important perioperatively. Closing capacity is greater than FRC, so airway closure during normal breathing, and obesity hyperventilation syndrome as late severe manifestation.
Was that the 3 headings for the table, or was that the other?
That's extra credit if you can have time to mention it.
Do you think just from that perusal answer, would you, if you were in that situation writing in the perusal for this question, would you remember all that?
No chance.
And so that to me is like such high level answer that like you would probably capture a majority of those points at the level you guys are at now, where you're trying to peak to get to, your exam sitting next year. But what I'm finding really useful is that it's giving you some really key buzzwords. And what I want to know is, are you guys recognizing these are the key buzzwords using AI as the tool? Like the last question, the key buzzwords were like cooperative binding. This one, the key buzzwords are there with closing capacity. How is using ChatGPT enabling you guys to recognize like those are the words? Because what I found really difficult, and the reason I'm asking that, was when I was studying and I was reading West's, I found it really difficult to know what was important and what was garbage. And some things that I read, I'm like, that's not important. And then I'm like, why was that thing that was mentioned once like keeps getting repeated like 5 times?
I feel like it's a sort of a similar thing. I think like the common buzzwords in these answers, I feel like with doing multiple SAQs, you see them pop up multiple times and they get repeated. And so I feel like you just take a bit more notice of them. I think initially you don't really pay much attention until you see it again and again and again. So I think similar sort of thing to what you were saying with reading West, that you just kind of like, oh, that's popped up again. But yeah, what do you think, Robbie?
Pretty similar. I think the importance comes through in seeing the SAQs and seeing what concepts are repeated. Like, I don't know, for example, cardiovascular physiology, systemic vascular resistance, and the factors that contribute to it keep coming up, that Hagen-Poiseuille equation. And that just keeps reinforcing into my mind factors there that are important. I think that could be missed potentially if you're just using only AI. But I mean, even here, looking at these answers that it's given me, it's highlighted some of the factors. So cooperativity is highlighted, sigmoid curve is highlighted. I guess, yeah, allosteric modulators is highlighted as well. So I guess it is trying to emphasize, and I guess, like you mentioned, Arnie, if you're concerned about it, you can just ask, what are the most important factors here? And we could see what it says.
Yeah, it's really cool to see what I think is important is the things that are also being highlighted, given the knowledge that I think I have, and it's not to the level where I had it at 2022. But it's cool that it's like it's picking up on the same things. I'm going, oh yeah, those are the buzzwords that were important.
Yeah.
Cool. Shall we keep going? The next one?
All right, yeah, next one. Outline the physiology of nociception using the following headings: stimulation of peripheral nociceptors, impulse conduction along a primary afferent nerve, synaptic transmission at the dorsal horn.
All right, that's a minute. This one, luckily I've done recently because I've just gone through pain physiology. So I think I have a good grasp on this, but I think the examiners are being really nice so far in this paper. They're giving you headings, which tells me like they really don't want you to waste time and they want good answers, is the theme I'm getting of this review so far. Like here, they're giving you tell me about the nociceptors, tell me about the primary afferents, tell me about the dorsal horn. And so I wouldn't even have a definition of pain. Like you could have a definition of pain, but it's not asking you that. And because they're being so direct, and that's the theme I'm getting, I'm just going straight into the answer. So I've written here in my perusal, no definition, just to remind myself not to waste time. And I've gone nociceptors. They can either respond to chemical, thermal, mechanical. They can be polymodal or unimodal. and there's multiple types, and that's all I've left. And you know that there's going to be lots of different types you could talk about, different channels, sodium channels. Primary, I've just written A delta and C fibers, fast, slow. That's it. And then you can go through characteristics. And then dorsal horn, you can make this really big, but I've just said the key things I want to remember is talking about the rex lamina, talking about the substantia gelatinosa, talking about the transfer onto the main pathway, which is the spinothalamic tract. And so I'm just going to hit that and talk about the Lesueur's tract and key details on that. And whether that involves, because it's just, I think the question was just talk about the dorsal horn, the dorsal ganglion. So I would say it's the transfer to second order neurons. And so whether you want to go more into that, I don't have anything. And because they're not really asked about clinical here, if I had time, maybe I would talk about clinical and what you could do to block each one of these sites, but it's not specifically asking for about that. But it was in the back of my head and I put question mark clinical. I don't know whether I put it in.
Yeah, my answer was pretty similar. The stimulation of the peripheral nociceptors was almost the same. Spoke about what activated it, like the different stimuli, mentioned two main fiber types, and a little bit about transduction. And then when it was talking about the impulse conduction along primary afferent nerves, APs conducted to dorsal horn of spinal cord, speaks a little bit more about the A delta and the C fibers and like speed of them and character of the pain. Cell bodies are in the DRG, and that's pretty much all I had for that. And then synaptic transmission of dorsal horn, exactly what you said. Talking about the second order projection neurons going to the spinothalamic tract. Speaks a little bit about modulation, so inhibitory interneurons, and a little bit about descending pathways. But yeah, very similar to what you had.
Yeah, nice. Yeah, that's a good key point, was the modulation part, because that is also happening in the second order area. So I think that would be a very important part in this question.
Yeah, only thing that might had is in the first section also mentioned sensitization. So I guess how inflammatory mediators can lower the threshold and lead to hyperalgesia. We'll also mention transduction mechanism. I'm not sure if you guys mentioned that, but actually activation of ion channels. And then mention some specific ones there. And then like Harry said, also in the second point, mentioned modulation. So local factors like ischemia, acidosis that can affect conduction. And interestingly, sodium channel blockers can interrupt conduction. Not sure exactly how relevant that is, I guess, because you mentioned no clinical aspects, but and then in the last one, the only extra thing it had in terms of modulation was to get control theory.
My question is this: given these three questions have had pretty distinct headings from the examiners, sometimes the examiner report subsequently will be like, we wanted this extra level of information. And I wonder if these questions, that's going to be the feedback, where they wanted that extra level of information, like you said about modulation, like you said about peripheral sensitization, which wasn't specifically asked for, but I wonder if those are the things that will be like candidates who had these got extra marks. Or was it just as simple as, I think you would pass if you had just the basic stuff that we talked about. And I wonder if you would get like a high 4, comfortable 3 to a high 4, and almost like a 5 if you had those extra parts. And we won't know until the examiner report comes out.
Yeah.
But it's definitely, I haven't looked at this paper, so I'm doing this completely blind as well. But this is definitely one of the few papers where it seems like I've not had 3 questions in a row where they've told you exactly what they wanted. So let's see what the fourth question is, because if they don't ask me what they want, I might be struggling on trying to think of things.
Next question then.
Yeah.
Describe how the kidney handles and regulates potassium throughout the nephron.
All right, that's a minute. You guys are probably smashing through this. Your AI questions are coming up answers are probably coming up way quicker than me. But I hate this question. When I was doing my Vivas, I was hoping that Lachlan Rathie would not be asking me this, because Lachlan Rathie loved to ask this as a Viva question, and it came up like the sitting just before mine. And it was like the first time they were like asked about the renal handling of potassium in a viva setting, and some people just bombed it. But
Mm.
I would just start off with like, I started off with a really basic one because when I struggle, I just go back to basics. And I went, plasma potassium level is kept between normal levels of this and this. So that would be my opening statement. I said plasma levels, and I said normal potassium that is excreted or reabsorbed to the kidneys. And then I just broke it down into proximal convoluted tube, the loop, descending, ascending, the DCT collecting ducts. And I said, and I couldn't remember, but I thought main reabsorption was either in the PCT or in the loop. And then I just told myself that I have to think about two extra things here: the effects of hormones regulation, so aldosterone, and then the effects of acid base, because potassium is normally exchanged for hydrogen ions. And so those were the key things that I was going to hit, and I couldn't miss. But I couldn't remember the exact core details, so I'm interested to see what ChatGPT said.
So mine broke it down into, what's that, 5 subheadings. So first one was filtration, and it just says potassium is freely filtered at the glomerulus. Talks about proximal tubule reabsorbs around 65 to 70% of filtered potassium, and that's done via solvent drag and paracellular pathways. Loop of Henle talks about the thick ascending loop, about 20 to 25% of potassium is reabsorbed there. DCT and collecting duct, it talks about the principal cells being the main site of regulated secretion. And it kind of just goes a little bit into a bit more depth with that. I don't think you'd ever write all this in a minute of perusal. So like some of these get into a fair bit of detail. And then it talks a little bit about the intercalated cells can reabsorb potassium during hypokalemia. And then regulation, as you said, aldosterone, talks about distal tubular flow, acid-base status, and plasma potassium concentration, directly stimulating aldosterone and increasing secretion. But yeah, like I feel like there's a fair bit of information like written down. I don't think you'd be able to write a fair bit of this in a minute. I'm going to get a couple of the keywords down, but this goes into a little bit of detail.
If you were to just ask ChatGPT, could you re-summarize that 5 subheadings into like just one word or like 2 words? Can you do that while Robbie says what his ChatGPT said?
So my ChatGPT was pretty similar actually to Harry's. It just had an introduction as well, which is very similar to what you had, Annie. So daily balance, intake, excretion, tight regulation of ECF concentration, and the kidney is the main regulator. Then it had nephron handling, which was in the proximal tubule, loop of Henle, distal convoluted tubule early, and then late distal convoluted tubule and collecting duct. And it's highlighted that this is the key regulatory site. And that final urinary potassium excretion is determined, in this site here. Then it has gone into quite a bit of depth into regulation as the next subheading, which would be aldosterone, distal sodium delivery and flow rate, acid-base status, plasma potassium concentration, and other hormones, so catecholamines and insulin. And then it's given me a little bit of an exam tip as well. So it says, in perusal, sketch a quick nephron diagram with potassium handling sites, just a quick nephron diagram, nice and easy. And then it's asked if I want this mapped against my uploaded renal physiology text, including Vander's, Guyton, and Ganong.
Jeez. That's not actually, it sounds crazy, but that's not a bad tip, because if you just drew that, even if it was just like a line, the loop, a line, and then the collecting duct, and you put 65%, 20%, remaining percent, whatever variable, you'd probably get you'd easily just get like a 1 or a 2, because you at least know that majority of it's reabsorbed in PCT.
Yeah.
Which is the key thing,
That's
right?
true,
Because you're only ever manipulating a small amount. Even with sodium, you're only ever manipulating a small amount with aldosterone. Because if you manipulate a large amount, your body would be way out of whack. What did ChatGPT re-summarize yours to, Harry?
So just said filtration, it's freely filtered, proximal tubule, 65 to 70% reabsorbed, solvent drag, paracellular, in the loop of Henle, 20 to 25% reabsorbed, distal tubule and collecting duct, principal cells, secretion, intercalated cells, reabsorption, regulation, Aldosterone increases secretion, flow rate increases secretion, plasma potassium concentration increases secretion, and acid base alkalosis increases, acidosis decreases.
All right, pretty reasonable. So the key thing there was understanding that your DCT is where you're going to get primary regulation, either through changing flow rate, aldosterone, or changing acid-base balance.
Yeah.
Nice. So far, ChatGPT is absolutely killing it. Probably killing it too much, and now it's
I
making
think
me
too much, yeah.
And now it's like making me a bit worried.
But I'd say you're killing it too. I'd say you're giving it a
No,
run for its money.
no. Let's go to the next one. I'm waiting to fall off the cliff right now.
Next one is outline the mechanisms which influence the rate of gastric emptying using the following headings: local, neural, and hormonal. Do not include pharmacology.
What was the last heading?
Hormonal.
All right, that's a minute. Safe to say I've not thought about this in a long time in the primary setting. I do think about gastric emptying, but I do not think about the factors. And so I don't know if these are even the right factors. I had for local, neural, and I'm going to just chuck them all to one. I started off with just saying the gastric emptying varies based on food type, and so the half-lives change. So I just remembered to say there's different half-lives for fluids, proteins, and carbohydrates. I think it goes fluids, then carbohydrates, then proteins. And then those would be my local factors. Neural, I would talk about the autonomic nervous system and positive and negative feedback loops. And then I would also link that into hormonal, being positive and negative feedback loops. I couldn't think of all my hormonal things. I know CCK was in there. I also knew the composition of food in your duodenum affected the composition of food in your in your stomach. So I knew that was an important feedback factor, but I couldn't remember everything. So that's what I had as a basic overline.
So mine had for local factors, increasing gastric volume increases emptying due to increased stretch and tone. Then it looks at the composition. So liquids more than solids. Solids requiring, I don't even know what that says. But then it talks about like increased fat, increased protein, increased osmolarity, decrease emptying, pH of less than 3.5 and the duodenum slows down emptying. Neural talks about enteric reflexes, so gastric distension increases antral contractions. Duodenal receptors, so stretch, fat, acid, and hyperosmolar chyme provide an inhibitory feedback to the stomach. And then, as you said, autonomic balance, so talking about parasympathetic and sympathetic. And then hormonal talks about CCK leading to a decrease in emptying, secretin decreases emptying, GIP decreases emptying, and motilin increases gastric motility and emptying.
Nice. ChatGPT killed me there. That was a very good answer.
Mine was very similar. I think, so I mentioned in the local mechanisms that duodenal feedback is the primary regulator. It's emphasize that there. And the factors that influence that. In neural mechanisms, split into intrinsic and extrinsic. So intrinsic being myenteric plexus and gastric distension, extrinsic being parasympathetic and sympathetic variables. And then it's also mentioned the gastrocolic reflex there. And then hormonal, like Harry said, CCK, secretin, GIP, motilin, and gastrin. And then how each of those influence it. And then it's given me exam tip during perusal. So write the three headings: local, neuronal, hormonal, and then it's given me the main points there as well that should be mentioned, which are the things we just discussed, but in a truncated view.
Does your one have you put as a parameter to give you exam tips at the end?
No, I haven't. It's just for some reason gives me an exam tip right at the end.
That's pretty cool. Like I just noticed that's like you've been getting these exam tips, which are probably all I would actually realistically write in my perusal time.
Yeah, I agree actually. Yeah, because exam tip is a very truncated, but probably what you do in a minute in perusal.
Yeah.
But I have put it like in the prompt. I'm saying like to do this like during perusal timing. So interesting that it still goes into so much depth, but I think it's probably learned because in all my previous questions or my previous answers, I usually have ended up asking, like, can you go into more detail? Can you go into more detail? So maybe at some point it's learned that I want as much detail as possible.
Yeah.
And I don't want brevity in my answers. So it's probably learned from me, and that's why it's doing that for some of my answers, potentially.
Nice. So this is another question that examiners are again giving you the headings. So there's definitely a intended theme here. So why don't we check what the next one is? And I feel like it's going to be another one that has subheadings to it.
So next one is A, define the terms tolerance, dependence, and addiction, 30%. B, outline the mechanisms and clinical significance of opioid tolerance, 70%.
That is a minute. Again, they gave us headings. So because they've said define, I've not spent much time, but I've got tolerance, dependence, and addiction. My simple definition of tolerance is increasing dose for the same effect. Example being high dose of opioids when using regular opioids. Dependence divided into physiological and psychological. And then it's commonly associated with withdrawal, and addiction is a known change in behavior that leads to harm. It's a combination of both people having dependence and tolerance in majority of states. And then the mechanisms for tolerance was the second part. And so I started off by just writing here, no exact mechanism known, just have multiple theories. And so classic theory is upregulation or downregulation of receptors. Or I know there's more, but I've just put, because I ran out of time, what did I put? Change in either receptor or intracellular mechanisms. You guys have anything different?
Mine's gone into, like I said, some very similar tolerance, dependence, and addiction definitions. It's also mentioned things about reversibility and specificity for tolerance. And it's highlighted that dependence is not the same as addiction, and has said addiction involves reward pathways. In terms of tolerance, so the mechanisms, part B, it's gone into two main ways. So pharmacodynamic mechanisms, which it mentions desensitization, so specifically uncoupling from G proteins, receptor internalization or downregulation, altered signaling, altered second messenger signaling, and NMDA receptor activation. And then spinal dynorphin upregulation, which is news to me. And then in pharmacokinetic, it's mentioned altered metabolism or clearance potentially. Then in clinical significance, it's mentioned dose escalation, incomplete tolerance, cross tolerance, hyperalgesia, and therapeutic implications. So the need for multimodal analgesia, careful distinction between tolerance, dependence, and addiction, and awareness in acute pain. And those are the general subheadings. It's given a bit more information under each of them.
Yeah, my definitions were pretty much the exact same. For my mechanisms, it kind of broke it down into receptor level, cellular signaling, and systems level. So with the receptor level, it just said mu opioid receptor desensitization, downregulation of receptor density, cellular signaling. So you get upregulation of the CAMP pathway, and NMDA receptor activation, which can lead to central sensitization. And then you can have nitric oxide involvement. Systems level talks about cross tolerance between opioids and incomplete tolerance to side effects, so miosis and constipation. And then clinical significance was needing escalating doses of analgesia. You've got a ceiling of efficacy, so limited by adverse effects. Hyperalgesia is possible, implications in anesthesia, chronic pain, and perioperative management.
It seems like both your chat GPTs have learned how each of you study.
Yeah.
Like it's obviously adapting, as the name suggests, to how you guys, because that pharmacokinetic, pharmacodynamic is obviously how you break it down, and then Harry, how you break it down to that cellular down level. It's really interesting. But if I was answering this question, if it was my exam, I would be thinking that regardless of whether you went pharmacokinetic or pharmacodynamic or the cellular way, that part of the answer is only going to be very short, because obviously they want a significant part to be clinical significance, because we don't know what theory it actually works. But as long as you just list the theory quickly, that clinical significance and relating it to patients in acute pain, chronic pain, how you deal with them, and using the multimodal would be the buzzwords to probably get you an pass mark in 3 or 4. Do you guys agree?
Yeah, absolutely.
Yeah.
All right, let's go. We're doing okay. This is late at night now. I do appreciate you guys sticking around. We're 8 questions in.
Yep.
Yeah.
This is number 8 now.
Only eight more to go. There's 8 more to go.
Yeah.
We got
8
this.
more, yeah, I think. All right. Explain the concentration effect and second gas effect in relation to the washing of sevoflurane with nitrous oxide.
That's a relatively quick minute. But again, they're giving you the headings for every question so far. I actually find this really ridiculous, but I find it quite. This is definitely an intended change. With regards to concentration effect, I just said it's 2 components: the decrease in alveolar. I just put decrease in alveolar volume and a change in minute ventilation, which increases the FA/FI ratio, so a faster effect. And the second gas effect is secondary to that, where you have a second gas that now in that same concentration gets a faster FA/FI. You need to use nitrous because you need to use gases at high concentrations or high volumes. So it only works with nitrous, and the only other gas it would work with would be potentially xenon at high concentrations. That's it.
My first answer had paragraphs for each section, so I had to say keep it more concise. So it's really shortened it down. So it just says concentration effect is just high FI gas leads to a faster alveolar rise. Mechanisms of alveolar shrinkage and augmented inflow. Second gas effect is uptake of large volume of nitrous concentrates the second gas, e.g. SIVO. Same mechanisms, faster FA over FI, rise of volatile. And the clinical effects are nitrous speeds its own uptake and sevoflurane wash-in, which leads to a faster onset.
Yeah, mine is very similar. In the concentration effect, it's split in, actually, both concentration and second gas effect is split into definition, mechanism, and result, which it's highlighted as you've both said. And then clinical relevance, it mentioned SIVO plus nitrous co-induction. It mentioned the magnitude of the effect and an additional note, which is that the reversal occurs on discontinuation. So diffusion hypoxia.
Yeah, and that was the question I was going to pose to you guys. Would you talk about the reversal effect? Because it hasn't asked you, but it's one of those things I could see the examiner report being like, the reversal effect was not asked for, but many candidates put it in, or candidates who put the reversal effect in scored extra marks.
It's annoying because you never know what they want, and it can go one of 2 ways. I feel like I would, because there's no harm in doing it, and I feel like it's low risk, high reward. So if you're going to get a bonus mark, then I think it would be worth it, and it's relevant. So I'd probably throw it in.
Yeah. The one thing that I would do if I was sitting this exam is I would put a highlight next to this question, because this question is one similar to the last question, which it was those are 2 questions you could smash out in less than 10 minutes. So I would, if I was as a tip, I would put that as like an asterisk as my catch-up question. So it's the question that if I'm running back behind on time, if I'm over my time limit by a minute or 2 minutes, and whether you're on the day trying to just time yourself to 9 minutes per question so you have a minute spare, but these are the 2 ones where I'm like, okay, if I can get them done in 7 minutes, I'm going to move on. So with that, as a little tip, that I used to have that. I remember on my day when I sat, my catch-up question was actually my last question, and I left myself 6 minutes to write it because and I got through it. But yeah, you just have one question that you're like, I can smash this. And it's generally not the question which you know the most about, because the question you know the most about, you invariably end up writing the most because you're like, I know so much about this. I just want to show the examiner that I know this question. And then you just waste time. It's the ones where it's like, I actually don't know too much about this, but it's not asking too much. I'm just going to answer the question of what it's asking me. So as a tip for future, for anyone sitting, just have one or 2 of those as your catch-up questions.
Would you start? So do you leave those catch-up questions to the end when you're starting to run out of time?
No, I do them. I did the exam in order.
Yeah, okay.
So I just had them like as per,
Yeah.
because the issue with changing order is you get booklets for each question.
Yeah.
And the one thing you didn't want to do in the heat of the moment was just accidentally switch up your booklets.
Yeah.
And if you did that, the examiner doesn't know, you get penalized, you can't switch it over. Like, I think they're a bit more nicer about it if you recognize it before you have to hand in your paper. But I'm just like, I'm just going to go in order because I'm going to just not think about that as an issue and just going to do that. So in my head, I just had the time that I wanted to get to and then be like, okay, whenever my catch-up question is, let's just see if I can try to catch up back to a round number.
Yeah. Yeah. Okay.
Next one. Let's do this. Home stretch now.
Next one is discuss the use of ketamine for intravenous induction in hypovolemic shock using pharmacokinetic and pharmacodynamic principles. Include and justify appropriate doses in your answer.
All right, that's a minute. I'm going to repeat myself. They're giving you headings: PD, PK, and justify. What I would start this answer off with is just a quick definition of hypovolemic shock. So you could either say percentages, you could say that hypovolemic shock has different stages. And so, because they've already told you the patient is in shock, are they 10%, 20%, 40%, kind of like how you categorize hemorrhagic shock, because that will also just help out, in my head, my justification. With PD and PK, the two important things I wrote here was that it still has negative inotropic effects, but it increases sympathetic output. And so somewhere in there, I wanted to write, if sympathetic output is maximized, then all you're going to get is still just the negative inotropic effects from the pharmacodynamic principles. From the pharmacokinetic principles, the main thing is it's fast onset and it's analgesic. And yeah, you have norketamine, but that's the key things that I just wrote. And it doesn't really matter anything about distribution metabolism, but I think the key thing they wanted you to put in distribution probably would be that in a hypovolemic person, your VD is decreased, so your dose is decreased. So your dose adjusts. So as long as you, in my head, if you had put the stages of there's different grades of hypovolemic shock, it helps to then grade what the pharmacokinetic changes are to then justify. And so to justify what my dose would be, my first line was I need to write my dose would be based on clinical effect endpoint being dissociative anesthesia. So either are they showing nystagmus, are the eyes wandering off? And so I would start off with doses between 0.25 to 0.5 milligrams per kilogram, not 1 to 2 milligrams per kilogram. And repeat aliquots and wait 90 seconds because that's the onset of time, or 60 seconds, and wait till effect.
I had very similar things. Again, I had to ask for it to be more concise because it gave me pretty much a full exam answer. But from PK, it just says short IV onset, 30 to 60 seconds, large volume of distribution, hepatically metabolized to norketamine, clearance is decreased in shock, so you'll have a prolonged effect. Smaller dose needed because you get an exaggerated effect from decrease in volume of distribution and decrease in clearance. PD, from a CNS point of view, you get dissociation, amnesia, and analgesia. CVS, you get sympathomimetic responses, but if patient is catecholamine depleted, it's a direct myocardial depressant. Respiratory, you get minimal depression and you get bronchodilation. And then clinically in hypovolemic shock, maintains blood pressure and cardiac output versus propofol and thio, preserves airway reflexes, dose reduced from usual 1 to 2 to approximately 0.25 to 0.5 mg per kg, and to watch for myocardial depression in severe shock.
Yeah, mine's very similar, I think, in the PK/PD. Interestingly, it didn't highlight, I think, as much as it should have, the reduced central compartment with hypovolemic shock specifically. It tended to focus a bit more on clearance and reduced clearance, how that can prolong duration of action. In the pharmacodynamics, it mentioned the direct myocardial depressant, but also the advantages with the sympathomimetic activity. And then in terms of, it had a little subheading after that saying clinical significance in hypovolemic shock. So advantages, maintains BP and cardiac output via sympathomimetic, preserves airway reflexes, provides analgesia for trauma. In limitations, it's mentioned, as we mentioned, the catecholamine depleted patients and increased ICP if head injury. And then some comparisons to prop and thio. And then dosages, it said normal induction 1 to 2 milligram, but in hypovolemic shock, reduced dose typically 0.5 to 1. It said milligrams per kilogram titrated to effect. May use smaller incremental boluses until desired depth achieved. And then it's also mentioned iron route possible.
That's pretty good. I think we are seeing that it is comparing to what I would say, which is not what I'm not saying I'm correct, but it's comparing to what we think would be the most important headings.
Mm.
And it's most importantly looking like it's giving the exact same thing between you two. So let's try to rattle off these last 6. We'll just quickly go through them. We'll do double speed. I'm just going to do 30-second perusal, and I'm really going to struggle now.
All right, my computer is lagging a little bit. For some reason, it's just not really working super well, so we'll see how we go. All right, next one. Discuss the factors affecting duration of action of a local anesthetic block to a major peripheral nerve.
Okay, that's 30 seconds. You know what the first thing I wrote was not speed of onset, because this question has come up so many times when it's been like, discuss speed of onset, discuss duration of action. So I've just
Discuss both.
Discuss both. So I've written not speed of onset. Interestingly enough, it's just, I feel it's the same factors. So I've just got subheadings
It is,
being
yeah.
concentration, type, adjuncts, blood flow, and then nerve type. And so whether that's the nerve is in a fascial bundle like a pop sciatic, or using an ultrasound to identify nerve type to deposit as close as possible, because that's also going to affect. So those were my brief headings that I had.
Yeah, my overall headings were drug factors, adjuncts, local factors at injection site, nerve or block factors, and then patient factors. So it sounds like very similar things.
Yeah, mine's probably very similar as well. It has the local anesthetic factors themselves, and those are all the PK factors that we mentioned, nerve, block, and site factors, and then adjuvant factors as well, and then patient/systemic factors.
Yeah, nice. So you could either break it down like patient, drug, other factors, or you could break it down into PK, PD, other factors for this question. If you were like thinking category, like that's going to be my subheadings. Cool. Next one.
Compare and contrast the pharmacology of atracurium and rocuronium.
That is 30 seconds. First line was for me table, PC, PD, PK, atracurium, rocuronium. 2 different drug types, benzyl. I can never say it.
Yeah, it's a hard one.
Aminosteroid and the benzyl. You know what I'm trying to say, guys. It's late at night. We're recording this late at night. Main differences on just pharmaceutics was that one was stereoisomer, and the main PD difference was just dosing and the ED95 dosing. And then the main PK differences was just excretion. So that's all I had.
Kind of concerning. Mine didn't even mention doses. So mine just spoke about class, time of onset, duration, metabolism and elimination, metabolites, cardiovascular effects, reversal, and clinical use. But yeah, no mention of any dose anywhere.
Yeah, mine had potency, but not actually dosing as well. And then, yeah, similar otherwise points. It also mentioned side effects, I guess.
Probably what I missed out was what you said, Harry. I will put in clinical relevance is probably the important, because like at the end of the day, if you're struggling, you got to go, why are they asking you about this? And it's because one drug can be used as an RSI and the other drug is not used as an RSI.
Yeah.
And in UK practice, a lot of people use atracurium. Not many people use ROC. And ROC is mainly used for RSI purposes. And why is that? Need a high dose, Bowman's effect, all those other things. And then PK, and then the other important clinical thing was the reversal, which I failed to mention, but I think that would be a key thing that you would not want to miss.
Also mentioned that organ independent metabolism is a clinical use for atracurium.
Yeah.
Next one.
Yep.
All right. Outline the pharmacology of amiodarone using the following headings: mechanism of action, pharmacokinetics, adverse effects, adult cardiac arrest indications, and dosage.
That's 30 seconds. We've gone from 1 minute to 30 seconds now. Have you guys found that now the exam has gone into pharmacology mode.
Mm.
Yeah.
Like,
There's some themes to it.
yeah, they've definitely divided this up. In terms
They
of
have,
this,
yeah.
I don't think there's anything to add. Like, you just say what they've asked. Mechanism of action, class 3 antiarrhythmic, potassium channel. If you want to get more into it, you can talk about other effects that it might have. Pharmacokinetics, I just wrote, important thing is that it can be given PO and orally. Has a large distribution from what I remember,
Mm-hmm.
and then the metabolism is variable, and the excretion, the elimination half-life can vary as well. And then main adverse effects were, I just try to remember the couple of things that I don't want to forget, and that's going to be pulmonary effects and thyroid effects and drug interactions. So those were the key things I want to hit in this. And then cardiac arrest, 5 milligrams per kilogram, indication. First thing you want to write is, I just wrote shockable arrest after third fail shock. Anything else?
Mine's just gone into a bit more detail about those adverse effects. Quite a lot there. And then clinical note, adverse effects are common with chronic use, less relevant in acute resuscitation. And then in terms of the cardiac arrest dosages, it's mentioned 300 milligrams IV-IO after third shock. Follow-up of VF or pulse VT persists, additional 150 with a maximum dose of 450. And then follow-up, if Ross can consider an infusion at 900 milligrams over 24 hours. And it's for some reason mentioned the formulation there as well, which does not seem like the right place for it.
Mine had the exact same stuff. Yeah.
I feel like when they've got such like distinct headings, both your chat GPTs just line up.
Yeah. Because I think it's
That's
just
true, actually, yeah.
key points of each of these headings, and it's just kind of just got to be the same thing.
Yeah, cool. All right, last three, go.
All right. Draw and label a Mapleton F breathing circuit, Jackson-Rees modification of Ayres TPs, 20%. Explain how it works during spontaneous ventilation breathing, 100% oxygen, 80%.
Minutes up. Well, 30 seconds is up. I don't know what I would write for the perusal. I honestly don't know what I'd write for the perusal for this, because I would actually just skip this perusal. Because there's no point. I started to draw this in what we're doing right now. I'm like, why am I drawing it? I'm just going to redraw it again on the exam paper. The perusal paper doesn't get drawn. So I just wrote low dead space, lightweight, good for spontaneous breathing, especially in kids less than 20 kilos. And that's all I had.
I feel like I would write the exact same thing. Then this just kind of goes into, for part B, this breaks it down as like inspiration, expiration, key principles. So there's no rebreathing if you have a higher fresh gas flow. Advantages are it's got low resistance because there's no valves, therefore it's useful in peds. Lightweight, as you said, and then limitations are requires high fresh gas flow and it's inefficient. You get a waste of oxygen or volatile agent. But otherwise, I feel like it'd be the same. I feel like this would be one of those questions that you just wouldn't really scribble anything down in perusal. You just crack on.
I think the same principle, you know, how I said about picking time for when you're writing in the exam paper, it's the same principle I had for perusal. If there was something that I could just like skip and I'd have a minute left on perusal, I'd be like, sweet, this is an extra minute where I'm mapping out exactly what I'm writing for the first question, because this is just an extra minute for me to get for the exam paper. Yeah. So I had that same principle, like wherever I could steal minutes, I would try to steal a minute.
And yeah, I feel like, yeah, it would be such a benefit to be able to identify those questions that you're like, I'm comfortable enough with this. I can put more time to something that could flesh out a bit more. Yeah, no, I totally get that.
Did yours have anything different, Robbie?
No, mine was identical to Harry's.
Cool. And the key thing, I think, is just making sure where you put your oxygen input into your diagram.
Yeah, to make sure it's a Mapleton F and not one of the others.
Yeah, and knowing that your bag is open, which everyone will know, but it's the oxygen part which always confuses people. It's the main kind of difference, usually, with the different Mapleton types. Cool. Second last one?
Second last one.
Wow, we're nearly there.
All right. Outline the pharmacology of the following diabetic medications. A, glipizide. B, metformin. C, empagliflozin. Using the following headings: mechanism of action, side effects, perioperative cessation, and recommencement.
All right, that's a bit more than 30 seconds. I was drawing the table. But I would just have this as a table. And again, it's like all pharmacology and equipment has been left for like the last 5 questions.
Mm-hmm.
And so you would just have like in any order, sulfonylurea, biguanide, and an SGLT2. And your mechanism of action would be altering as per what the drug class is. I think the periop cessation and stuff, where I wrote just a quick note, kind of links into side effects, because perioperatively you'd stop your metformin on the day of. And so your side effects for your metformin is usually like you're trying to avoid lactic acidemia, but that's only if you get, bad renal impairment. Same with your perioperative stopping of your SGLT2, you're doing it 3 days before to stop the side effect of your diabetic ketoacidosis or euglycemic ketoacidosis. You have other side effects too, but they kind of just link in. While your glycoside, your main side effect you're trying to avoid is hypoglycemia. And so you also may or may not stop that on the day of. And you could even take this a bit further and said, is the procedure in the morning, is the procedure in the afternoon, if you had time, because those headings don't seem like they would take 10 minutes. So again, I would flag this and be like, can I quickly draw this table? Can I smash this question out in 7 or 8 minutes? You guys have anything different?
No, pretty much the exact same stuff. And I think like mine's kind of bolded all the stuff that you said with like the perioperative cessation, recommencement, and exactly what the risk of continuing it is. So yeah, hypoglycemia, lactic acidosis, euglycemic, DKA. So yeah, it's touched on all of the same main points.
Yeah, mine's also given just a really quick, it says exam-friendly table summary, which is just highlighted mechanism, side effects, and perioperative advice, but just very succinctly. And I think that's actually probably something you could scribble down during perusal if you wanted to before getting into all of it.
Nice. All right, guys. Last one. Just for the ones that are listening at home, I want to just say that Harry and Robbie are doing this recording at 9 o'clock at night, and Harry has worked all day. And so that's why we've been trying to power through these last 5 questions. And I want to just thank them again before we get to the end. We are on our last legs.
All right, last one. Explain the principles by which an ultrasound can generate a 2-dimensional image. Do not include Doppler.
All right, that is 30 seconds. To finish off, I always hated ultrasound questions.
Yeah, geez, me too.
They are my least favorite questions of any equipment questions. I hated them with a passion. And I don't even know if you need to define an ultrasound, because they're asking you a very poignant question, which is just how to generate. But I felt like I've written here define, because it'll help me then establish how I'm going to tell them how it generates a 2D image. So some definition is the sound frequency wave above the audible frequency, whatever you want to put in there. And then I've just got a diagram or like a pathway: generation, interface, receiver, and I would break it down into those sections. So I'd probably just do a table with those things. And in those, I put key terms being the frequency wave equation and then acoustic impedance as like the 2 important things. Because all in my head, all an ultrasound is trying to do is delineate what different tissues are and then get that information back. And it's a combination of your crystals changing shape to give that sound wave and then bounce back again to recognize that sound wave. And the only thing that sound can't go through is hair.
Yeah, interesting. Mine's taking a bit of a different approach. It's given a definition, generation, and then it's split up into 5 points. 1, generation of ultrasound, which is mentioned in the piezoelectric. Then 2, interaction of tissue. And it's actually gone into quite a painstaking depth there, not just acoustic impedance, but also all the other ones: reflection, refraction, scattering, absorption, attenuation. And then it's gone to how it detects the echoes, and saying that time delay and amplitude are proportional to a difference in impedance. And then image construction, and just mentioned the specific modes there, all of the ones that we know, and the factors that affect image quality, so resolution and artifacts. So I guess that's probably more depth than I would have gone into answering this question, because it specifically says physical principles by which it's generated. But maybe some of these factors here are things that would score extra marks. I don't know, maybe like the factors affecting image quality, the different image construction modes specifically as well. Not things that would have come to my head immediately with this question, but maybe things that would be beneficial.
Mine had almost word for word what you said, Robbie. Generation of ultrasound, propagation through tissue, detection and processing, formation of 2D image. Pretty much exactly the same sort of stuff.
The only thing I would add is probably the one thing I would retrospectively put back in is clinical significance of using different ultrasound probes, because it's asking you about 2D imaging. And so you could then put in how a low frequency probe, like a curvilinear, versus a high frequency probe in terms of image quality for superficial and deep structures. And so that would probably be the clinical thing I'd put in instead of like the other clinical things, if that makes sense. Or like not the clinical, like the variation of how a 2D image is improved or made worse.
Yeah, how to improve like the quality of it depending on
Yeah.
Okay.
Guys, we did it. Thank you very much for showing me how AI works. I hope the people listening have got something out of this. I know that I have, and I've probably said the word that it's amazing, like, I don't know, 10 or 50 times. For someone that never grew up using AI, in terms of when I was going through both my exams, to now seeing how AI could have been so useful, I think people are probably going to be like, damn it. They're going to be like, I wish I had that when I was studying. And because they feel that way, they'll probably be like, oh, it's a crappy tool, because they'll probably feel like they missed out on something. And I think the other thing is that doing this perusal and going through these questions shows that this is actually like, I don't know, it demonstrates to me it's quite obvious. It's a very credible tool. Yeah, not everything is perfect, but when you read a textbook, there's no guarantee that a textbook is perfect either. How many times have we read multiple pharmacology books and be like, hey, that VD in one book is completely different to the VD in the other book. Which one do we go with? And there's slight differences in the pKa of certain drugs. And so you have to take it with a grain of salt. And at the end of the day, they're looking for, in my head, if you understand the broad concepts, you'll be fine. So I think we have proven that AI is a safe tool to use and a good tool to use. Do you guys have any last things you want to add on it? Like if you were trying to convince someone now that you've used AI and was about to start their journey, would you convince someone to use it?
I think so. I think the main benefit of it has literally just been saving time. So not having to look through and trawl through all the different textbooks and trying to figure out which textbook is most reliable for what part of physiology or pharmacology. Just having all of the resources in one spot and just being able to have a quick answer that kind of answers what you're looking for, I think saves so much time, which makes study more efficient. So yeah, I think that's the big benefit to it. So I'm a big fan of it. I'd do it again.
Yeah, same for me. I think I'd advocate for people to use it. I think, yeah, one example that comes to mind, that before I used AI, there was this learning about opioids, and there was about how it interacts with volatile anesthetics to affect cerebral blood flow and cerebral metabolic oxygen consumption. And like having read Mac 95 in the textbooks, I could not understand it. And I just had to accept that I wasn't going to understand it. And that did not sit well with me. And then when I started using AI, I came back to it and I challenged it about these concepts using the textbooks and, kept asking it the things I didn't understand. Like, oh, but what doesn't it work like this? But don't opioids do this? And eventually I could reason down to a way that I could understand how that works. And I think whether or not that helped me learn it better, I don't know. But I think at least not having that uncertainty that just gnaws away at you about, this concept now that I don't understand and I'm never going to understand because I can't get it. It just helped me understand it. And I think that that helped a lot.
It's also really good in like trying to clarify if you understand a topic. So rather than like reading through a textbook being like, yeah, I think I get it. It's similar to, you can kind of compare it to talking to someone who actually knows the answer to the question that you're asking. So the amount of times I've just been like explain, I don't know, the Bohr effect, and it gives me an explanation of it. And then I can literally just type back to it and be like, so in essence, is this correct? And I'll give my interpretation of it. And it'll be like, you're close. This is a very common pitfall, or it'll be like, yeah, that's bang on. That's exactly what it is. And so it's nice being able to get that immediate feedback from what you're considering to be a credible source, as opposed to being like, yeah, I think I get it. And then you'll be trying to explain it to someone else. And you're like, I don't really get it at all. I don't understand it nearly as much as I thought I did, or I'm just completely wrong. So it's nice to be able to get that like immediate feedback and I guess validation of yes, you get it or you don't.
I never thought about it that way. That is a very interesting way to think about it, actually. And I wonder if that will change how, on a final note, how we actually just do teaching in general in hospitals for the exams. Whether we have someone who's actually gone through the exam, facilitating teaching, but we have AI assisted teaching.
Yeah.
Because if you have a tool that can individually help everyone understand in their own way a concept, isn't that better than one person explaining in a way that
made sense to them?
Yeah.
Yeah.
And maybe that is the future. And a part of our job now is to convince the older generation, including me, that this is actually a beneficial tool, that this is the tool that we need to be using to not only think about how we study, but to think about how we're going to be teaching people so that we can tailor make studying.
Yeah. And like a lot of I think Chat GPT has like I think Gemini does too, where you can literally just talk to it and it will verbally talk back. And so I guess you could try and use that to practice for like vivas if you've got someone physically asking you a question and then you're actually practicing verbalizing it rather than typing it up. So I guess there's different implications for using it as well. So yeah, I reckon it'll definitely become more of a thing with education later on.
And I guess the factor we haven't even mentioned is, sometimes if you don't understand something that you think should be commonplace, like you might be a bit embarrassed or fearful to go approach your consultants or professors in this topic, not understanding something that seems rudimentary. Ultimately, the AI is not going to judge you or make you feel stupid for not knowing something. So if I have to ask it, what is an arm? How does the lung breathe? How does the lung work? It's going to tell me. And no one's going to talk down to me for not knowing. I think that's probably an element we haven't considered too.
And I think on that note, we will end this episode here. And I want to thank you guys so much for taking time to do this episode. Hope and not only like to share your wisdom on a topic that I'm very much unfamiliar with, but also go through this at a very late time in the day and go through the exam paper. So thank you guys so much. And I know the people listening to it, whether they either like it or dislike it, will have learned a little bit about AI. So I appreciate it very much. Thanks, guys.
Thanks.
No, thanks for having us on.